Okay, so in the last video, we talked about the primary purpose of the DSM, the definition of case formulation. So let's go down to this content here that the gathering, organizing of data, formulation of diagnosis, considering cultural factors and social circumstances. So that's all stuff that I've added in reflection to the definition of case formulation. And the reason why I added this content in addition in the video around it is that this is also reflective of how we're going to approach our virtual case studies in this course, right? And coming back here to the the virtual case study template. All right, if you're looking at this in the video. All right, so let me walk you through this. It is a little bit of a the instructions of the virtual case study. This is a little bit of overlap with the instructions themselves, but this is also a good way to reinforce sort of not just the assignments, but central to what we're doing in this course, which is not just learning about these diagnoses and learning our way around the DSM, but also learning and practicing the process of doing good assessment and case formulation, all right, which is central to good assessments, good diagnoses, and good treatment and an intervention planning. All right. All right. So gathering our data, right? So our data comes in a number of different ways. It comes from what our clients tell us. It comes from what we observe, what our clients, that includes what our clients communicate to us non-verbally. And they may communicate a lot, and not just in person, but clients also communicate a lot in telehealth sessions as well. You may not have the full body language to read in telehealth, but there is a lot of nonverbal communication that still happens in if you're doing telehealth care. So sometimes you'll have some adjunctive data, and sometimes you won't have any. Many times you won't have any, but other times you will. And those are good perspectives to have, even if you might read a legal record, or maybe you read a police record that reads as somewhat unfortunately maybe even a school record or something that reads as somewhat pejorative to the client, or a spouse or other family member that with the client's permission has provided you information, and they're like, well, and they're have a perspective on your client that may be somewhat negative, or at least reflective of frustration. All those things, and you take that all in context, right? You take that all in context. So organizing your data. So a couple things. What appears to be primary? And of course, in the virtual case study, we won't be able to ask our clients that. Part of our exercises will be seeing if we can glean, or what are our impressions of what appears to be primary for that client. Sometimes that's very obvious. Sometimes we have to sort of ponder that a little bit. And that actually is reflective of how clinical work can be in real situations. Okay, so and I think primary risk factors and protective factors are another good way to organize your data. All right, and those are not just for safety and suicide assessments. It really, to me anyway, and this is why I include it in our exercise. It's a good way to help you organize what may be a whole lot of data coming at you in a very very quick, or what feels like a very quick manner. Okay. And then also, what data are we missing? Even when you get to spend an hour with the client, just them in a quiet outpatient setting, you may come away with, there's like a bunch of questions I need to ask, or things I need to know. And a lot of times after I meet with someone for the first time, even if I have spent an hour with them, there's often like, there's things I want to ask about, or sometimes I'll say that openly, depending on the particular context. I may say, oh, okay, hey, we're running, our time is getting towards the end. I just want to say out loud, there are a few things I wanted to ask you about next time, if that's okay with you. All right. So those are all things that help you organize your data. Informing your diagnosis. Now we'll get into this as we get into using the DSM's words, disorder sections themselves, and we look at individual diagnoses and disorders. We'll walk through that process of, okay, again, you're not going to memorize the criteria. You want to get a working familiarity with it so that over time you're able to translate that data you're getting into, oh yeah, that meets that criteria. And likewise, as you get more familiar with criteria and you get more familiar with the DSM, you're like, okay, that combination of criteria usually points in this direction, so that you are beginning to able to start create pathways for yourself in your own head about, okay, this collection of data or this type of data tends to point to this type of criteria, and this combination of criteria usually points in this direction, and then you can go and dig further from there. The reason why, well, there's a lot of reasons why that's important. One of them is that so you can work your way backwards. Like, here's how I arrived at this diagnosis. All right, I didn't just do it on conjecture or that's what I think. I based it on evidence. So you go, here's this diagnosis is associated with this criteria. Here's the data that matches up with that combination of criteria, and that's how I arrived at my diagnosis. All right. And then, of course, all those cultural factors and social circumstances are wrapped up in that, right? So it's not just here are the symptoms they're reporting, or here's symptomatology that I'm observing. It is getting all that stuff in the client's context. What is going on in their lives? What's happening currently? What may be from the distant past that's still having a very direct and significant impact on their health and their distress and their level of functioning now. All right. So, and so all of this then becomes, it's sort of a methodology towards doing not just sound assessing and creating diagnoses that you can defend, that you can explain, here's how I arrived here. Because sometimes you might find yourself in circumstances where to advocate for the client, you can't just say, well, these are my credentials and this is what I think because of my credentials. You say, well, this is how I arrived here. And then just make this up on conjecture. This is how I arrived at this diagnosis. Wrapping in all those cultural and social factors as they are relevant for your individual client's case. Okay. And also creates the discipline for us to make sure we are gathering all those factors, that we're not just, okay, symptom 1, symptom 2, symptom 3. All of this is in the context. What's happening in the client's current life, current circumstances? What's occurred in the previous circumstances? What's very micro to them, and what macro things might be weighing on them in an individual way? Okay, and we can put that all together, and that all helps us do good client work. And that's really, I guess, what it all funnels back to, or that's the idea anyway. Last bit of here, diagnosis require clinical training, obviously, and this is why, although people will increasingly go to the internet, into all kinds of different social media and health media and news media type of platforms to try to understand what they're experiencing. Diagnosis still does require clinical training, and in my opinion, still requires human observation, human work. All right? I don't think that's going to change anytime soon. We may have technology that can help us in that, but it will not replace us, at least in my opinion, at least anytime soon. And of course, the ultimate goal, I think we've already talked about. All right, so that is, again, I'm creating a sort of a focus on this content because this really gets to the heart of what we're trying to do, or at least I'm trying to help you guys do in this course, because I think this will pay a dividend to you doing good clinical work beyond this class.